Sorry.
We just started recording. He has clinical expertise both in pediatric GI disorders as well as GI disorders and CF, pediatric gastrointestinal motility disease, and disorders of the gut-brain interaction. His research expertise focuses on gastrointestinal motility in CF, exploring the small intestinal and colonic contractility in CF. He's a member of the CFF Task Force for remote endpoints and research guidance, and has been an awardee of the CFF Digest. So thank you very much, Dr. Patel, for joining us, and I'll turn it over to you.
Thank you for that, very kind introduction. I feel very, good about it now. Oh, I have done all this activity because no one has actually ever read it to me like this before. So great. So these are my disclosures. And again, I think please ask questions because it's not important for me to get through all slides. Is it, as much as important to have discussion. So please, don't hold back, for the later. Yes, you'll have time, but who knows, so if you have questions, just, jump in and I'll just stop and try to answer as much as I can. I don't have any financial disclosure. I wish I would have something, but no, unfortunately. I've received a Digest grant from CF Foundation. And earlier, I think, one of the moms saying, Emily probably, that there are not many GI doctors in CF. And Digest grant specifically is designed to help recruit, more GI doctors to train in CF Foundation. So I did have that grant. And I'm not going to talk too much about the CF liver disease today because it's, a too extensive discussion. And, I don't feel like I have much to say on that at the moment, since there are just very, not many interventions that you can perform. I think many of you may have seen this video. I think it takes 5 minutes, but it may help to understand what is wrong in a CF and, kind of makes, or builds the basis in which direction we are going. So I'm just going to, play that video and see, give you like 5 minutes to kind of, listen to that and let me know if you're able to not hear or, hold on.
Yes, we can't hear it. If there's sound already, we can't hear it.
You can't hear sound?
No, I think you have to hit the share screen, hit on the share screen button, and then you have to click optimize for video. There's like a little, you have to click in the middle of the green arrow.
Yep,
rectangle.
Video clip.
Yes, if you click that, then we'll be able to hear the video. Yep.
How about now?
When you eat a meal.
Are you able to hear the video now?
Yes.
Okay.
The food and liquid travels through your gastrointestinal tract, breaking it down into the vital nutrients and energy your body needs. The GI tract is a long, muscular tube that has its own nervous system, with 5 times more nerves than in our spinal cord. These nerves are responsible for peristalsis, the involuntary reflex that propulses the food from one part of the digestive system to the next. For people with cystic fibrosis, the CFTR mutation can cause nerves in the GI tract to function poorly, causing potentially serious issues. The muscular valve at the end of the esophagus, called the lower esophageal sphincter, normally prevents acid from refluxing up from the stomach. This may be lax in CF. Once a meal enters the stomach, it mixes with gastric acid and other fluids to begin the digestion process. The muscular sac contracts against the pyloric channel at the end of the stomach to churn the food into small particles. When nerves malfunction due to the CFTR mutation, the stomach may become paralyzed, a condition called gastroparesis. With gastroparesis, the stomach can't expand. You end up feeling full more quickly when you eat. The stomach is also unable to empty, causing nausea, vomiting, and bloating to occur. This can increase acid reflux and lead to weight loss. The pancreas and bile secretions are critical for digestion. A healthy pancreas produces the body's natural antacid called bicarbonate. as well as the digestive enzymes critical for digesting what we eat. This includes fats, carbohydrates, and protein. The liver makes bile, which helps this digestive process. When the mushy food mixture leaves the stomach and enters the intestines, the bicarbonate neutralizes stomach acid and provides the optimal pH for pancreas enzymes and bile to function. In CF, fixed secretions in the pancreas block the pancreatic ducts, preventing the enzymes from entering the small intestine, and eventually leading to scarring of the pancreas and minimal enzyme production. The 20-foot-long small intestine is where 90% of food digestion and nutrient absorption occurs. The small intestine secretes fluid into the intestine to mix with bile and enzymes. It produces a thin, watery mixture to maximize digestion and absorption of nutrients across the cells of the intestinal lining. The bacteria that lives in the small intestine also aids in absorption. With defective CFTR, motility may slow, causing bloating, gas, bacterial overgrowth, abdominal pain, and distension. In patients with CF, thickened secretions can prevent effective absorption of needed nutrients. The large intestine, or colon, is responsible for processing any waste. With CF, sticky mucus and poor motility can cause constipation, making it hard to pass stool. CF can also alter the microbiome with more bacterial bugs that may lead to pain and may increase the risk of colon cancer. Cystic fibrosis has many debilitating effects on the gastrointestinal tract. Understanding how and where this damage is caused will help the development of more effective treatments.
All right. Let's go to next slide. All right. For some reason, I lost the Zoom screen. Are you guys still able to see my survival slide?
Yes.
Okay. So there was just a video to just give an overview of, GI related manifestation in CF. So what you're seeing right now is the survival in the CF. And why we're talking about all this today is because the survival has gradually up. And I think this data is actually from 2016 registry, meaning that hopefully, I really hope that the survival will increase even more, after this Trikafta. So it's very important that we understand that along with the survival, the problems are going to go higher too, right? Like the prevalence of disease conditions that will go, up too. So some of the GI manifestations, and we'll talk like each individually very, briefly, but those are extremely common, as we discussed earlier before we started the presentation. Poorly understood. There are no, good explanations why things behave the way. And earlier we heard someone saying that, one CF patient has X, Y, and Z, but then siblings doesn't have the same manifestation. It can cause abdominal pain, decreased appetite, increased malabsorption, and more importantly, this decreases the quality of life and reduced survival, especially the nutrition. CF Foundation conducted a study called Galaxy study, and we surveyed about 400 patients, and you may be surprised to know, but even though their lung is underlying, as main issue, quote unquote, but their GI dysfunction was one of the leading reason why they're unhappy with their quality of life. It's not their lung, it's GI tract. So it's about the time we address some of these conditions, or at least try to look into it, as opposed to, saying that, hey, the lung is FEV1 is good, therefore you should be great, take your pancreatic enzyme and everything is great. It's not the case. 85% patient would have pancreatic insufficiency, develops usually early, very early on, including, neonatal age or infantile age. And some studies even showed that patient with the CF, when they're born, a lot of pancreas damage has already been occurred, in utero even. Pancreatic enzyme supplement does not return to completely normal absorption. And that's not the only thing wrong with the CF GI tract, which is, I think I have to say, unfortunately, not other physicians other than the GI, know this fact. So what else is wrong? Number one, CFTR is not functioning. CFTR is very, integral part of, getting the bicarb secretion out from the glands. So don't have your bicarb, which is an, alkaline substance. So your stomach acid, is going to trickle through in the entire GI tract and essentially make everything acidic. So no bicarb, no buffering mechanism. Sorry, did someone ask anything? So higher than physiological, pH, that would make it everything very salty. So, your intestinal tract is super salty, and what happens is you have this thick secretions or mucus that's like make it, very viscous raft of, secretion that's very hard to penetrate. Likewise, the bile, the material coming from liver, is also too salty. Also, because of CFTR, the mixing of the content doesn't happen doesn't happen properly. So it's poor mixing. So all these factors causes or contributes to the GI manifestation. So you can see on the left, the track is pretty much clear. It's a normal track. On the right side, you can see how those gooish, yellowish, thick secretions are kind of sitting in the intestinal tract. And imagine if you have this thick secretion along the entire intestinal line, how difficult is that, for anyone to kind of, you would have symptoms, there is no doubt about it. So we published, kind of this hypothesis, in Journal of Cystic Fibrosis recently. And what I think in my mind, CFTR has two kind of issues. Not everything is one lump in the GI thing, but so I divided this, and this is my own slide. CFTR defect has primary insult, which is on your left, which says, again, I'm sorry if it's too small to read, but abnormal smooth muscle function. So the way we have muscle outside of the body, in the GI tract, those kind of muscle exist and called smooth muscle. And enteric nervous system, that likewise, our brain and spinal cord is our extrinsic nervous system, but then there is this GI tract, specific nervous system that we don't see it. The cells itself acts like their own nervous system. Those are the two main, problems, and that's why you're seeing all these issues. Not able to move, motility issue, all of that, because of the primary insult. And then there are a lot of other secondary effects on your right side, which is, pancreatic insufficiency and bacterial overgrowth and gut inflammation or dysbiosis, meaning that abnormal microbiome. So this is kind of a fundamental CFTR issues. Now let's dive into each, manifestation, briefly, just so that, if there is specific interest to any of this condition, you can grab onto that, and the rest of you can kind of, learn more on this. At any time, if you ask patients in CF clinic, 70 to even 80% will have pain. I mean, I have yet to see people say, oh, no, I'm GI, completely fine. I have no issue with the GI tract. So it's actually underrepresentation when I say 70%, but it's even more than that. And pain frequency is, from 10% to 50%, anywhere between that. So it's very large spectrum. Pain is more common, with other issues, but more importantly, it causes, anxiety and depression, not only to patient, but within the family too, because imagine every time you go and, child is complaining complaining of pain, and you can't do much about it. It's definitely, hard to kind of even think, it's a personal connection. I feel like it's very hard for caregivers. Poor physical function, competitive, sports and things like that. It's always, a problem. Impairment of sleep and restrictions of activity. And as you get older, restrictions of work. So I also want to kind of highlight this, the CF related issues, it predominates, but it's not the only reason. So I don't want that to be forgotten. So that's another reason why GI needs to be involved, because then we can look for other, reason. Give me just a second. I don't know why I'm not seeing any. Are you guys able to still see my slides?
Yes,
We still
I
see the pain and CF one, yes.
Yep.
Okay, all right. So
it does have a black bar above it, though.
Huh?
It does. There's a
It
black
does
bar
have
at
a
the very
black
top.
bar. Yeah.
Because I don't know what's wrong. Resume. All right, let me resume it. Because I'm not seeing when I change the slide here. Is that changing for you? I'm not entirely sure.
We still see the pain and CF slide.
Okay. At any point, if you're not seeing, and if you're losing me, please say something so that I know, because I can't see any of the attendee's face or a Zoom screen, and this is a little different, but it's okay. All right, so let me just go with the previous slide. So non-CF related pain can exist. So we have to make sure that there is no lactose intolerance, celiac disease, inflammatory bowel disease, a general GI bread and butter disease. It's so constant that patient may not mention, unless you ask. So they're so used to it, like the quote unquote start, used to a pain. So they may not even mention that. Another question we always want to stress is the lung function and nutrition relationship. So there are few studies that shows improved nutritional status, more healthful, especially at age 4, is associated with the better lung function and better survival. And this is the data. I will not read it to you too much in detail, but pretty good study, not like 50, 100 patients. It's like 3,000, 4,000 patients. And all of them, did really well, if the nutrition is maintained. So this is the question, right? Impact of nutritional status in early life, and the function and survival through 18 years of age. So, and this is what I just said. I think the weight to age percentile more than 50th percentile at age 4 reach at much more higher height in life and maintain this into their adulthood. Pulmonary function, which is measured, if someone doesn't know, FEV1 percentage predicted, was low in patients whose weight to age percentile, which is what WAP stands for, less than 10%. So it's very, very important to maintain the proper nutrition to even have better lung function delayed in the life. I think this is just a graphical representation, what I just said. This is another study showing the nutrition and FEV1 decline, where you can see this graph where the solid line represents underweight patient. The dotted line is overweight, and kind of semi-dotted is adequate nutritional patients. And if you look at the left axis, which is y-axis, FEV1 percentage, meaning that their lung capacity is the highest, out of all this group, which is good news because now we know where to intervene. So conclusion is this, we discussed already: improved survival and nutritional, better pulmonary function. So this is just a summary of what could go wrong in nutritional aspect. So left side says more calorie expended, which is what your CFTR mutation, is causing. You have stomach conditions like gastroparesis and poor motility and pain and social factor, psychological factor. Those are affecting your calorie intake. So you're consuming less calorie, but you're burning more. On top of that, you're losing more, which is again on the right side, malabsorption, pancreatic insufficiencies, diarrhea, small bowel, bacterial overgrowth. All these things combines to a very vicious cycle of malnutrition, which is very hard to treat if you are not sure which area you are, targeting. Because and sometimes, I would admit that this is multidisciplinary, thing, but still, it's always important to identify, are we dealing with poor calorie intake for whatever reason, or this is only because CFTR is burning more calorie, or this patient has colitis or Crohn's disease, or celiac disease that we haven't caught. So it's important to think from more than one perspective, and you just have to get yourself out of the CF, box, because we all can kind of get, tied up with, okay, we're seeing patients with CF, therefore everything is wrong. The CF is to blame. Probably not. Nutritional management, and this is, in general, some principles. Skinny people are not acceptable, meaning that we have to do something early on so people can get to their, final potential. Pancreatic enzyme replacement therapy is, good. It's not 100%, but it's definitely needs to be there. The other common and myth is non-compliance. I mean, the question that you guys just asked, it tells me that you know what you're asking. So sometimes, medical community has this, I don't know, just to assume things that they're not compliant, and there are partly patients like that too. But you have to also think outside of just non-compliance. If you don't take pancreatic enzyme, you will have some symptoms, but you will also have symptoms even if you take everything as you're prescribed by your provider. And why more pancreatic enzyme is not better? And this is older problem. So on your left side, you're looking at the histology slide, which is what the pathology doctor would look under the microscope. And where the arrow is pointing, it's in the ACE, site A. On your right side, you're looking at the barium study, just to highlight the colon and look at the intestine. So you can imagine, you can see on the right side particularly how narrow the part of the colon. I don't know you see my pointer or no, but this area, bottom 20 centimeter, it's not, very much, it's not looking normal, right? It's kind of a contracted and not very, flexible like the other part of it. And it's called fibrosing colonopathy. The word fibrosing meaning that you have fibrosis, which is to say that you don't have a normal compliant and soft muscle. It has been replaced by a scar tissue in your intestine, and it's not opening or closing. So it's kind of, it's kind of a fixed obstruction. On the left side, histology, I don't want to go into too much of detail, but you see the layer of the fibrous tissue. So more pancreatic enzyme is not better. This side effect was observed years back, when there was no regulation. Now FDA has good regulation on how much high you can go on a pancreatic enzyme. So you don't see, I haven't seen a single patient, of fibrosing colonopathy. So, which is good. But this is to say that, oh, you have more symptoms, increase your pancreatic enzyme is probably not the right approach. This is clear difference where GI can intervene. On your left side, you see the growth chart of a patient who was hovering around that 25th percentile of BMI. All the blue dot around that, purple line, which is around 25th percentile. Patient had G2 placement, and after some time, you see the red arrow on your right side figure. The patient's growth is exponentially higher and is now at 50th percentile. So this is very important to achieve the 50th percentile, because so many studies, has associated survival and lung function with it. Back to nutritional management, some appetite stimulant medication, especially for pediatrics, they're not the best medication. People always say, what if I can give this medication so my child or children can eat more? They can, and you can try, there's nothing wrong with trying, but it will never restore your BMI to a 50th percentile. It might affect, give it a little bit of a boost, but not a definitive intervention. In other words, I would not replace the tube feeding over this for any patient. Other important aspect, use Miralax, or for this presentation, or I mean for this presentation I'll say Miralax, but polyethylene glycol, which is an osmotic laxative, which draws the fluid in your intestinal lumen and hydrates that. And you can imagine, right, from the initial figure, if you hydrate your GI tract, you have all this bad mucus raft that's sticking and adherent around it, might move, and it allows a little bit better mixing and better absorption. So the nutritional, growth and nutrition gets better. Also, I would definitely stress, how you give Miralax does matter. It's again, osmotic laxative are supposed to draw the fluid out of the intestinal cells. So you really need fluid, meaning that water, juice, whatever. So use whatever your provider said, to use, but mix with water or liquid, but drink or have, patient drink in 10 to 15 minutes. You cannot make a big jug and John is sipping around it entire day. It's not going to work. You need to have Miralax with water in 10 minutes entirely. It's easier said than done. I totally agree. But if they're able to only drink 6 ounces, do that rather than giving full 8 ounces and they don't, they leave halfway. Give it when they're most thirsty. Just use some tactics around it. Treat for intestinal bacterial overgrowth. You can do the breath testing, but using metronidazole, as a trial might be actually better rather than just doing the test, because tests are not always sensitive enough, and sometimes you have false results. Also remember, thick salty mucus is a great place for bacteria to live. So bacterial overgrowth is very common in patients with cystic fibrosis. If it's a short-term issue, consider the NG stands for the nasogastric tube, just the temporary tube. But if it's permanent, the G tube could be placed by endoscopic or interventional radiology or the laparoscopic approach. And definitely consider initial night supplement. And I'm sure your center's dietitians are very well aware of all these recommendations. If you're on a tube supplements, definitely encouraged to see GI doctors. And like we talked earlier, someone who has more expertise in CF rather than general GI. They're great, in general GI, but they may just look at their general GI practice and kind of, forget the CFTR part if they're not used to hear the issues. I've never seen patient who is regret getting a G tube. So this is just the fact. They're always happy. I would say that it's very difficult to, sometimes even the word convince, they're understandably hesitant because it is surgery and involvement in a lot of other things. But when you're persistent and you kind of explain that this is another medicine, that you need to take, they definitely see the worth in it. And eventually they will say, well, it was the best thing we did. I'm not saying that there are no complications with the G tube, but the ratio of complication to benefits much larger or much smaller, so that you have more benefits, less complication. This is just a brief range of the disease: reflux, bacterial overgrowth, motility problems, gastroparesis, meconium malleus, distal intestinal obstruction syndrome, constipation, and colon cancer. Pancreatic insufficiency, we talked about it, earlier. Asking about steatorrhea to patients may not be very helpful because they don't know what the baseline is. So they may not be able to tell you, and yet you're suffering from steatorrhea, which is kind of losing fat in your poop, essentially. We have to remember that our digestive tract has only certain grams of fat absorbing capacity. So you load them with a lot of fat, it doesn't mean that everything's going to get absorbed. In fact, they will feel bloated and stuff like that. So it's important to kind of adhere to a normal nutritional regimen and tailor according to the needs, rather than more fat all the time, you know. Um, uh, Sorry, I think we kind of talked about this earlier. So I'm going to skip that. The heartburn and GERD issues. Chest pain and GI heartburn is common because, again, thick saliva, persistent sinus drainage, sometimes cough and pulmonary issues, lots of medication and inhalers. And don't forget that, you know, as kids grow older, they will, you know, transition to inhalers, which is a known risk factor for esophageal candidiasis, you know, meaning that you will have fungus, you know, you could have, not you will have, but you could have fungus. And that's why they are having symptoms and not simply heartburn. I had a questions from someone and they asked, do toddlers with CF have heartburn issue now or will be present later on? Answer is unknown. I don't think that heartburn is something that toddlers can complain, especially when they're toddlers still, you know, they can still say my chest hurt, but not so much. But when they're young, they just have this food refusal. They don't want to eat. Vomiting, that's another objective thing. When someone vomits, it's kind of a you know, red flag that we need to address. So just know it could present a variety of spectrum at any age, but this is more so common in school age kids and adolescent rather than infant. That doesn't mean that we don't start acid medication for some other reasons, such as increasing the activity of pancreatic enzyme, even if they don't have heartburn. So that's that. Again, reflux, 30% of children and adults, and it could be associated with the reflux of bile from your intestine to your stomach. And remember, bile is a very toxic substance. So when it comes from intestine to stomach, it kind of, you know, irritates your esophagus and stomach line because it's not supposed to be there. Bile is supposed to be in intestine, not in the stomach or in the esophagus. Let's see. Oh, the gastrointestinal motility. This is another big topic, and as it says, I can't really cover the entire spectrum of gastrointestinal motility disorder because this is what I do. I do CF and I do GI, you know, motility. So there is a vast, you know, spectrum what could be considered the motility disorder, particularly in CF. So as you can see, gastroparesis and delayed, you know, intestinal transit, constipation, intussusception, which is, you know, in one intestine loop to kind of, you know, telescoping in the other. Findings are variable if you have motility problems, age dependent, and depend on what test you use. 10 years back, there were no tests for motility by and large. Now we have many tests, you know, available to detect that. The problem is disease is so old that people don't move on, you know, with the more research. I'm going to come to that. And, you know, that's why I think this kind of a parent advocacy groups are good, you know, good, because then you can, you know, vouch like, okay, this is necessary, especially to see a foundation which, you know, can fund us, you know, or people like me to conduct this kind of research. I think I wasn't going to actually plan to cover the gastroparesis today, but it looks like someone asked very intriguing questions about gastroparesis. So I decided to just kind of make this 3 or 4 slides just this morning. So the prevalence of gastroparesis in general population is low. First of all, I should define it. Gastroparesis is the inability of your stomach to push the food out in a reasonable amount of time. And that's also a debate. What is a reasonable amount? But before we dive into that, let's just talk about the numbers. So the prevalence is anywhere between 2.4 to 9.8, and that's usually considered in 100,000 person years. You know, this is a research terminology which, you know, needs to be, it's very hard to translate some numbers to specific percent. So that's why they had to use this. But I would say that, sorry, did someone have any question?
Someone else just joined, so sorry.
Okay, no problem. So prevalence in gastroparesis and cystic fibrosis was measured to be around 38%. That's a very high number compared to general population. But there's always this disclaimer that true incidence or prevalence is not known, because it's hard to say you have gastroparesis and you don't. Um, the reason why this variation and this ambiguity about the diagnosis is because methods are different. These are comparing apples oranges, so you use different methods for testing. The discrepancies in the meal, you can't feed someone McDonald's burger and fries and measure their gastric emptying time, and someone has a protein shake. So protein is going to empty faster than fat. So the studies across the spectrum used different things. So you really can't compare this. That's the reason why we don't know the exact number. If any of your kids who had this gastric emptying scan, you probably had to undergo this very regimented meal, and then they will take pictures at 1 hour, 2 hour, 3 hours, and 4 hours. American Neurogastrointestinal Motility Society decided to kind of act on this and kind of made a definition a few years ago. And collectively, the consensus was we should measure 4-hour gastric emptying scan. So next time you go see a GI doctor, if they really suspect this and if they want to order something, you guys have to mention that we need a 4-hour solid meal emptying scan. Not just any scan, but 4-hour solid meal emptying scan. That's kind of a standard to meet the definition. Again, poorly understood like anything else in CF. But the biggest thing I wanted to convey is the lung transplantation and vagal nerve injury. So vagus nerve manages a lot of GI tract sensation. And if you have lung transplant, there is a good chance that your surgeon inadvertently, injured the vagal nerve. And that's one of the most common reason why you develop gastroparesis after the lung transplantation. But it can occur with CF patients, even with the best lung function you can possibly achieve, and patients without diabetes or CF related diabetes. So it's in a general population in adults, it's common to have diabetes and gastroparesis, but in CF, not so much. You have other problems with CFTR gene that could affect this, and that's why you have gastroparesis, not because diabetic neuropathic gastroparesis.
Dr. Patel, I think there might have been a question. Excuse me a second. I think someone had a question.
Sorry, go ahead. I don't have that screen up, so someone may have to read it for me.
Do you have a question? You had your hand raised.
I did. My first question was, just in speaking on gastroparesis, you mentioned the vagal nerve becoming damaged with lung transplant. Can the vagal nerve be damaged through other procedures, like an EGD or something else of that nature?
Generally, no. So these nerves that we're talking about, those are like, like a sensation, like network nerve. It's not like one string, specifically there's the branches and stuff. So if you have surgery, and I probably rushed through it, lung transplant, fundoplication, hernia repair, and things like that. Sometimes even medications, opiate, that kind of stops vagus nerve from functioning. So it's almost not possible to injure by just performing EGD, which is typically luminal procedure. This has to be an open surgery where you go beyond your intestinal tract to fix things or change the lung out, things like that.
I understand now. You might cover this later, but I just wanted to kind of put it out there. I was curious if small intestinal bacterial overgrowth could potentially trigger gastroparesis or vice versa, if they work hand in hand in any way.
Sure. So that's interesting question, and I don't know that we have clear answer, because if you look at the CF population in general, you have both gastroparesis and small intestinal bacterial overgrowth. Patients who have only gastroparesis and patient who has only bacterial overgrowth alone. So it's very hard to connect this together. What I will say that not so much of gastroparesis, but because your intestinal motility is slow, you trigger the bacterial overgrowth because of slow intestinal motility. Because remember, stomach, does not have major role in SIBO or the bacterial overgrowth, because there are bacteria that live in stomach. and only selective. But because of gastric acid or the stomach acid, stomach can pretty much regulate its own, entire, its surrounding. Does that make sense?
That makes perfect. Yeah, that makes a lot more sense.
It's like pH. Now you go from stomach to small intestine. The pH from stomach, what do you think? The chemistry lessons like 3 or 4. So severely acidic. You come just a 10 centimeter down in small intestine where the whole bicarb efflux or the neutralization of acid happens, and the pH goes from 3 to 4 to 6 to 7 in that 10 centimeter segment. That 10 centimeter segment is responsible for your 90% of fat absorption. So if your pH is not neutralized, you will have lots of acid going in the intestine. Not lots of acid, also you are losing lots of fat absorption zone, so you will have fat malabsorption and a subsequent BMI issue. So I don't know that gastroparesis is directly associated with bacterial overgrowth, but slow motility is associated with both.
That makes sense. Yeah, thank you.
Great. All right. So there are no guidelines for gastroparesis treatment, and partly because nothing specifically works for one patient, like it's a combination of approach. And typical non-pharmacological, which is, you may have heard it, low residue, low fiber and low fat, more protein diet is approach. Unfortunately, a lot of patients, they might need to bypass their stomach. If it's not working and if you don't know when, you can't afford to lose the nutrition over a long time. So you have to place a tube, and when you have the tube, it needs to bypass the stomach. Otherwise, you're going to invite lots of issues, in future. Treatment, erythromycin, azithromycin, you have heard this, before, safe and commonly used. If you use azithromycin, then one of the recent study from my colleagues says, the liquid form is better if you use azithromycin, which is a new knowledge. We always did the tablet before. Other medications, domperidone, cisapride, those are very toxic medications and have major side effect. One of the newer medicine is procalopride, which has shown some exciting result, but unfortunately insurance does not like to cover it right away. But that is something that I would, I think the question also included that, is there a new research? The new research in adult gastroparesis, the procalopride has shown very, very good results. I can't say that for pediatric, but we use it anyway, because we kind of just steal from adult people and just use it on kids, as long as it's safe to do so. Distal intestinal obstruction syndrome, which I will say DIOS from now, a few minutes. Incomplete or complete obstruction secondary to feces or fecal mass, rather. It's more unique to CF. We don't really see distal obstruction in other patients, even with severe constipation. I deal with lots of patients without CF, but lots of motility issue, and I don't see why only that little segment on the junction of small and large intestine always gets affected in CF patient. It's always also seen more commonly in pancreatic insufficient patient. Thick, dry, mucus, undigested food, they kind of gather around that area. And I think there is a role of abnormal motility. It's very unclear to me, but that's where I think, my next focus at some point to kind of look at that area specifically and check the pressure and see what's wrong, why there is always a hard time. The CFTR is not only expressed in the ileum or the cecum, the ileum meaning the small intestine, cecum means the large bowel, the junctional area. CFTR is everywhere else too. Why we don't have an obstruction, let's say in intestine right after the stomach or colon? Why it's only that area is affected? I don't know the answer to that. Obviously, no one knows. It often starts with infrequent stooling and it progresses to painful stooling, and subsequently becomes like have no poop and severe pain. The last thing you want to see is the vomiting and belly distension. That means you're getting into the full bowel obstruction. And if you can appreciate the image on your on your left side, you can see that kind of a ground glass appearance where you can see lots of stool that's collected. And I don't know, you can see my marker, but this is the area I'm talking about. This is a big mass or lump that's obstructing that area. And this patient is probably, getting into the, distension of his or her belly and subsequent vomiting. How do you treat DIOS? So first of all, I should say, no one should go in the DIOS mode with a full obstruction. We, as a doctor, GI doctor, interested in CF, should counsel enough to give medicine on time. I make patients aware of the symptoms, give them liberty to use Miralax at home in increased dose, 3, 4, 5, 6, caps on, on a day or for a day or two, to open that bad buildup from happening and kind of hydrate that, area so that, it gets cleared. But if that happens, and you need it at some point, then you have to clear that from the below, called water soluble hyperosmolar contrast enema. So in other words, enema from the anus. And a lot of my patients, say that it's painful. It's not fun to have it. It usually works, but it can make a big shift in the intestine, so it have to get admitted again. But again, biggest message in this slide is to establish the long-term plan. Don't let patient roll on their own for 3 days where you can actually intervene. Train your staff accordingly. The first, tier person who takes the phone call, and we are actually doing something about it, kind of a quality improvement at our institution, where we're going to give this algorithm to our pulmonary, the lung nurses, because they have no clue about this, and they're the one that always the first responder for these patients. Constipation, it's a frequent problem in CF too, but probably not more common than general population. It's so prevalent anyway in general population too. Diagnosis should follow the general guideline, but management usually involves more of a osmotic stool laxative, which is lactulose and Miralax, rather than Dulcolax or X-Lax or Senna or the chocolate square. I want you to realize the distinction between the DIOS and constipation. Those are not same thing. DIOS means you have an obstruction. Constipation, you're just not going enough, but you don't have obstruction. So the lumen is open. It's not completely empty, but lumen is not obstructed. Diarrhea could be possibility in CF patient, and we already talked about pancreatic insufficiency and fat diarrhea, which is also called steatorrhea, and other reason. But don't forget other things like lactose intolerance or small bacterial overgrowth. And I have a slides we can kind of go over that too later on. Small intestinal bacterial overgrowth, common in cystic fibrosis. 50% of the study that excludes subject with this motility. This is tricky because I just answered, right? Someone asked the question, the role of motility issues, and bacterial overgrowth. We know that these are connected. I think there is no doubt about it. It's just hard to measure appropriately when you're excluding patients with motility issue when you're counting bacterial overgrowth. It's kind of counterintuitive, but I don't think we have. I mean, you can see Jackie Frigino, one of my GI colleague, I think she's at University of New Mexico, in 2007 they published this, so it's like over a decade now. So risk factor for bacterial overgrowth, stasis, when it slow down from slow motility, previous surgery. We have an audience today, few patients who had surgeries done. So if you have surgeries done before, your risk to have this bacterial overgrowth is definitely high. Gastric acid suppression. I can't, imagine that none of you are on the, some kind of acid suppressive medication, omeprazole or lansoprazole or some kind of medication, not always for heartburn as we talk, sometimes to actually have your pancreatic enzyme work better if you suppress the acid. And if you have thick intestinal mucus, that's the best place for bacteria to live, so that's the reason why it's 50% prevalence. Another thing that, pediatric patients may not care as much, but gastrointestinal cancer is now, I think, increasingly identified entity in CF population. All kind of cancers, have gone up in terms of esophageal, stomach, hepatobiliary, which is liver and liver and bile duct, gallbladder, intestine, colon cancer. Now, most other cancer does not have a fixed screening protocol, right? So optimal screening protocol is not established, but one of my colleague is at St. Louis University, adult GI doctor. She is designing something to identify the right age for screening, and also find out the non-invasive way to kind of detect the cancer in CF population. So right now, the recommendation is colonoscopy at age 40 and then every 5 years. If you have organ transplant, any organ transplant, if you're on an immunosuppressive medication, that age comes to 30. So as you can imagine, post lung transplant patients have high risk for developing colon cancer. So it's very important that we don't ignore just because the patient is young. Just to keep in mind, this is always hard to convey and kind of very worrisome for pediatric parents, but the incidence is not as high as in pediatric. It's actually more after the transplant if you end up getting lung transplant. Non-CF causes, I think we kind of scatteredly talked about it. You always have to rule out other things. C. diff, lactose intolerance, celiac disease, which is also known in a lay language, gluten sensitivity, Crohn's disease or colitis, urinary tract infection, stones in the renal system, the kidneys, gynecological disorders, musculoskeletal conditions like joint issues, non-GI but non-CF like depression, anxiety, and now I think we have to also start thinking about the post-COVID, issues. And this is very generalized, but I see a lot of patients with the post-COVID issues in general gastrointestinal, general GI clinic, who has IBS, and I'm not going to be surprised at some point there will be COVID-associated GI manifestation in CF population who has otherwise normal, baseline health. And of course, math test and anything that they can gain will have some GI symptoms. So keep that in mind. That's always the case. So we kind of talked about very briefly about a lot of things, and my goal was to give an overview. And let me just see the time because I can't see it. It's just like 7:10 from my time. So I wanted to spend a few minutes and kind of give you some idea about some new research. And I'm just gonna talk more about like generalized term, but you will have some understanding what is happening. So the new research is going in almost every area in the CF, not just GI, to be honest. But after the Galaxy study, and for those who joined late or did not have idea, what Galaxy study did is that all these GI doctors, all of us, we thought that, oh, this patient's complaining, GI issues, and why are we not looking at it? So we designed the study, gave everything to patients, and asked them to report the symptoms. And to our surprise, well, to our not surprise, to us at least, the GI doctors, the GI symptoms were very high, on their list that's impairing their life. So CF Foundation recognizes this, that, okay, this is the problem and we have to address. And then they design this DIGEST grant, which is I'm the awardee for. So this kind of things help to develop new science. I'm involved personally, all these 5 studies, that I'm listing here. We're looking at the acid reflux testing and lung transplant practices, meaning that some centers would do pH probe, endoscopy, smart pill, all this testing, and manage your acid reflux accordingly. Some people will just say, well, you have acid reflux, here's your omeprazole, you're going to take it forever, and they really don't change much. So we're looking in the different practices and the outcome comparison, whether the targeted approach is good, test and treat, or treat everybody approach is better. So that's one, novel research. And the research, why that research is important is because if you have uncontrolled acid reflux or GERD, you are not going to have a better outcome even after you get the lung transplant. In fact, GERD, severe GERD can kill your newly transplanted lung if it's not controlled. That's why we're looking at it very closely. That's one. The second study is the Miralax and wireless motility capsule. I am actually personally doing this at my center. This is not sponsored like CFF study. I wanted to see whether there is actual improvement in patient symptoms after use of Miralax, patients with history of constipation. Along with that, I'm giving them something called wireless motility capsule, which I will show you in a second. They swallow that, and that capsule, records pH and temperature and pressure. And I wanted to see, is there a benefit of Miralax to increase the gut motility? Because we all assume like, oh yeah, Miralax works and great. And I always tell that it works. It works is a different story. Does it really improve the GI motility? That is unanswered as of now. So that's the study that I'm running. The third one is also, I'm doing it myself, is something called IB Stim. And I don't know you have heard of this technology, but I'll show you the device and we'll talk more about that in a second. The other couple last studies are looking at the motility capsule, the smart pill that we just talked about, and the motility or pH on the bicarbonate, especially before and after the modulators, Trikafta or Cambi. Does that really change your bicarb or motility? I think the smart pill has the capabilities to answer these questions. And this is one of the reasons I was saying that 15 years ago, there were nothing. Motility studies, you forget it. There is nothing to measure. Now we have things. This is smart pill. You can see it's kind of a size of the gummy, or it's a little bit bigger than gummy, but it has a pressure sensor, pH, and temperature sensor. It can detect from one point to other how much time it took to travel. So you can actually say how much time it took to exit the stomach. So you can calculate whether you have gastroparesis or no. And total GI transit time, not just the stomach, but the intestinal or colon transit times, you can calculate as well. The problem is it's not approved for kids. So I'm at a pediatric center, I'm a pediatric GI doctor, but the studies are only for 18 or above, which is what it's approved for. And it does help kind of localizing the transit abnormalities. So if you say, oh, my GI tract is bad, but where at, is that stomach, small bowel, colon? This might be able to help us. And this is, something that I don't want you to kind of remember, obviously, but this is what it looks like. pH is in the green. The hot red is the pressure or the contractions in the stomach, and very small, faint blue is the temperature. So I think the pH is more important. And this might be something you can see. Earlier we were talking about when one of the question was the pH. So do you see, and sorry, this is one of my own patients, it's not very clear, but do you see how, this is the stomach, because the pH you can see on the lower scale, right? pH here, somewhere 3, 4, something like that. This capsule, are you able to see my arrow by any chance, or I'm pointing at a wrong place?
I'm struggling to see your arrow.
Okay, sorry. Now do you see this moving?
Now I see it, yes.
Okay, sorry. I was using my other screen. Let me kind of explain this again. So this is our pH graph. So pH here in this segment is low, 3, 4, something like that. The capsule goes, and do you see how big jump this happens in pH? It's because it is in a small intestine now. You can see the label pH from here, suddenly it went high. So you can sense that right here, the capsule was in stomach. Now the capsule is in small intestine. So there are things you can determine and do some research. In fact, I'm doing some of this thing myself, analyzing it. It's so hard to, this is tedious research. And you have to sit down, and it takes forever to analyze this. And, no one has time in the clinical setup. But the point is, there are new techniques that we can use and help localize the problems that were never explored before. This is the Miralax study that I mentioned earlier. We kind of, get the patient's consent, give them a 2 weeks where they're not on anything specific, complete the questionnaire for, constipation or pain, administer the smart pill first, then count or calculate the data, how fast it empties and all that. Then start them on Miralax for 2 weeks and give them Miralax for 2 weeks and do the smart pill again. And then repeat the questionnaire, repeat the data, and they compare these two data, whether the symptoms were better before and after Miralax, whether the data, the transit time, did the capsule went faster, from the GI tract after you cleaned them out. I think this will give a good information to push for more Miralax if it's really helpful. At the same time, it will give us an idea. If it doesn't help the motility aspect, but it does help the symptoms, then I think we can still, say that we have somewhat kind of, advantage to use Miralax rather than say it doesn't work. This is the IB Stim, the device. I have a grant from Washington University and NIH consortium to kind of study this. What you're seeing is the device that goes behind your ear, and it has 4 little leads that goes, 4 areas, and you can see 3 areas that it's stuck right now. The 4th one is kind of hard to see. It's right behind your, top part of the ear. This device or the lead targets the branch of vagus nerve. The reason why we selected the ear area is because vagus nerve ends in your ear, and it's kind of, spread on your external ear outside in the surface. So if you stimulate the vagus nerve and kind of program it to process the pain in a not so harsh way to your pain sensing area in your brain, then even though there is that low, lurking pain in CF, but your brain may not process that as a pain. And that's the whole idea. Now I do this, this is disclaimer. I have a grant from the company to do this for, a patient. This is FDA approved by, any means. So from 11 to 18 years of age, patients are qualified to get this as a treatment. So I do this for non-CF patients in my clinic regularly. You might have more questions about it, but I'll just answer a few so that, you can ask further if you have any. But this is done every week up to 4 times. So I place this on Monday. Friday, they take it off. The patients take it off at home. Remind you again, these are not CF patients. These are IBS patients, 11 to 18s in my motility clinic. They take it off at Saturday morning, and they can do shower and other things, on the weekend. They come back on Monday morning, I place it again. I do it for 4 times, which is what the FDA is approved for. And this is supposed to modulate the pain sensing area enough that it can sustain the improvement for sometimes a year, sometimes 6 months, or sometimes 10 months. That number is not known yet, that how long would it improve? I have done over 20, 25, in other patients, and the response rate is about 80%. Since the mechanism is almost similar, I think this may help RCF folks, RCF patients to have at least a little bit of improvement. I'm not claiming that this will 100% alleviate the pain, but it would make your quality of life from pain 7 or 8 or 6 out of 10 to 2 or 3, something more tolerable. So that's my IB Stim part. I think a couple last more slides and we'll, stop after that. Intestinal manometry. Manometry is the process where you actually place the catheter inside of your intestine and actually see the contraction rather than depend on the wireless motility capsule to give you that contraction that I showed you earlier. This is the gold standard test. And I do this on patients every single day. It is a process. You have a clean out, do the colonoscopy, place the measuring device, you stay in the hospital for a day or so, and we measure. But the advantage is I can exactly place the catheter where I want to, and the catheter will show me the contraction nicely going from one point to other. And if there is something wrong with the segment, let's say 10 centimeter of part of the colon is not contracting, I would see this, on my, the computer screen myself. Especially, and we kind of do some tricks too. We give bisacodyl, glycerin, things like that through the catheter. This catheter has a lumen in the middle, and we can inject the medicine in an intestine and kind of see the effect of the medicine. But unfortunately, there are no studies in cystic fibrosis. This is, I would say, somewhat invasive. So this is not that as easy as it sounds, or I made it sound. So to do the study, I need to kind of provide the proof of concept first. And that's why I'm doing the motility capsule study, so that it's not invasive. But if I find significant difference on that, then I jump on to say that, look, now we have that differences. Maybe there might be a role of this test that we're doing in other thousands of kids. Why not to use it on the CF patients too? Again, disclaimer, CF patient has bad lungs sometimes, and the anesthesia risk and all these to be considered. But there are plenty of times that they're getting the bronchoscopy or other anesthesia, and we could sometimes, try and do it together. Just for you guys, the resources, CFF website has digestive research segment. So you can always click on that, and then clinical trial finder, tool, which I'm sure you're aware from your centers in, CF directors, and they must have given you all the information. But plug in there, your kid's age and the issues, and you might find some trials that may be relevant to you. And of course, clinicaltrials.gov is a federal website you can always log on to. So to summarize, GI disease in CF is a clinical challenge. And then gastroenterologists can definitely help prove and improve the care and prolong the life, frankly, especially with the moderators or the modulators era. And then significant patient experience the GI symptoms, even with the careful enzyme adherence. So I'm not surprised to hear in questions, okay, even though we are doing everything we can, it's still, have issues. Nutrition is directly linked to health and survival, and hydrating your GI tract does help a lot. So with this, I acknowledge Sarah Jane, from University of Minnesota, who has, been my mentor, and Jeff Techman from my own institution, and he has personal connection with CF, and he has taught me a lot. And some of the slide content were taken with their permission in this presentation. So with this, I will stop and open the discussion for questions.
Thank you very much. I think there was a question someone had about whether Trikafta would be able to correct GI tract issues in CF. And I think you mentioned briefly that that was part of the research that you're looking at.
Sure. So Trikafta, there is good news for that specific, person who asked the question, because Trikafta, so first of all, I should say it's not enough time to conclude anything for Trikafta yet. However, I wasn't part of it myself, but Sarah Jane, I just mentioned, acknowledge her. She presented that in one of the meetings. They did the 6 month of analysis of GI symptoms improvement in patients with Trikafta. Interestingly, it was 430 patients. They found bloating gets better, BMI gets better, lung function gets better, but unfortunately, there was no striking improvement in other GI tract manifestation. Now, I will clearly say that this is only 6 months and it's only 400 patients. If you change this to 6 years and 4,000 patients, you might see totally different reason or the conclusions. So I wouldn't be discouraged by that. But the most recent abstract that we had at the NACFC meeting did not find great improvement, but it did find an improvement in BMI. So that is a good news, because BMI improves. And I was talking to our CF Center director, and he's like, our inpatient census is very low. Patients are not getting admitted because they're gaining weight. Their GI tract symptoms are much better. In fact, he told me that he routinely asked these questions in his CF clinic, and patients are actually saying, even voluntarily, that Dr. Noyes, I haven't told you this before, but I don't feel the pain that I used to feel before since I started Trikafta. So even though study did not find that correlation, but it's not the study, it's just the midway analysis. I still hear opposite. I hear there are a lot of improvements in GI tract. Oh, I think I answered most questions. I think a couple of you guys were worried about what's long-term impact on GI with 24-year-old not being compliant, not taking enzyme for several years. Unfortunately, you will experience malabsorption, nutritional deficiency, and some GI symptoms otherwise you could have, or you would be able to prevent it with the help of pancreatic enzyme. So compliance is an issue, especially when you get to that age when you think like everything is going to be just fine, but you don't see this until you break your bone, and see vitamin D is like 3, then you realize, okay, well, I'm not losing just fat, I'm also losing vitamin D. So unfortunately, I don't have much answer there. There will be some impact on GI tract if we don't, kind of do what's suggested, at least, from the guidelines or the evidence-based research. And I hope,
Jordan has a question.
Sorry, I'm just reading off the other questions. Is it common to have bouts of intermittent nausea? Not so much, unless, intermittent nausea, it's something that if it's not associated with vomiting, it could be just hypersensitivity in the GI tract, which is possibility with the CFTR mutation. But sometimes I would make sure that this intermittent bouts of nausea is really nausea and you don't have underlying ulcer. That's because every now and then you have, some reason why patient is nauseous. And if you have acid touching that ulcer, the exposed area, you may have, this nausea and sometimes vomiting. So I would make sure that there are no other GI reasons for patient to have nausea.
Dr. Patel. Okay.
Yes,
So
sorry.
I know you have the list in front of you, but 3 people here have asked questions in the chat.
Okay.
So
let's see. Now I can see the screen. Could SIBO potentially? I think we talked about Amy's question. Emily, any trial specific to Trikafta and the GI in the works? Yes, it's called PROMISE, PROMISE study. And PROMISE study is evaluating a lot of things, and a big database being built on PROMISE study to look at all the specific GI aspect, including smart pill or the wireless motility capsule. So I'm going to request actually to get the PROMISE database in 6 months from now to see if I can evaluate the same thing that I've been talking, So yes, there is going to be a great database. Does quality of food we take have an impact on GI tract? Yes, it does, but I'm just generalizing that in the sense of processed food versus not processed food. I don't think that there is any specific like quality, meaning that high fat or low, high organic versus non-organic food. I don't think there are enough information on that, but I do think some G2 patients, they do well on hydrolyzed formula or blenderized diet formula. So if you have a real food like organic blend diet, sometimes it tends to be absorbed better. Unfortunately, you have to have a specific size of G tube to administer that, and it takes significant effort from the family too. So it's not as easy as it sounds, but food does have definitely an impact. I would be hesitant to say scientific impact on the GI tract. So those are the questions that I see, and those are the questions. I think I have one more question that I did not cover. Is there something that I could see in stool that I should immediately call a doctor about? I think I would say blood in stool is abnormal. You should not see blood in stool, by any means. It could be as trivial as it's constipation, and you have just a fissure at anus, and that's causing blood, which is, by and large, most common reason. But you could have polyp, and you could have celiac disease, you could have colitis, Crohn's disease, vascular malformation, a lot of other reasons. So blood in stool is kind of a warning sign to call the doctor or actually see them, not just call. So I guess, with this, I have the entire list covered, and most comments, I think we covered that.
I think
yes.
Jordan had raised had a hand raised, so I don't know if Jordan, you want to ask your question?
Yeah, first of all, Dr. Patel, I wanted to thank you for a very informative presentation. I learned a whole lot, and I really, really appreciate that. My overall question is that you had referenced Miralax several times throughout the presentation, and I was wondering, at your center, have you seen any adverse reactions to it, such as behavioral or the body just not handling it very well? And if you did, what did you use as a substitute, or what did you recommend?
You said Miralax, right?
Yes, sir.
I deleted that slide, specifically. Give me just a second. I would like to share that so that we can kind of, I'm going to open the other slide that I presented. I will probably, I thought that I had that slide somewhere, but let me answer the question in a brief, way where, I can say things with confidence. So first of all, I think and sorry, I just could not find, at some talk I had that slide, and I'll send it to you, Jennifer, afterwards, so you can disseminate that if you have the emails. So I guess the question was the Miralax, right? Jordan, is that correct?
That is, sir. Yeah. If we've seen kiddos in the community have sensitivities to it for quite some time now. Yeah. And I just want to know, for those that can or have seen behavioral issues with it, what can we recommend and substitute for it?
So there was this big discussion about the Miralax causing lots of behavioral issue, and you probably have seen it, all over the internet and stuff. And I can reassure you that, that the component that is active, like the active ingredient, actually does not get metabolized or absorbed. So polyethylene glycol has the other molecule that, as an end result, it gets, kind of metabolized too. And the study, the reason I, don't remember exact same, but the study was from nationwide, from Ohio. They measure that material in patients' blood after Miralax use, in variety of patients, and none of the patients, or majority of patients, they did not have elevated chemical that was deemed very, toxic or known to cause behavioral issue. So the whole notion, I think the discussion around the Miralax was challenging, because 70% of our patients, they asked me, okay, should we stop this? And no, and the answer was yes, do not stop this. There is almost no reason to believe that Miralax is actually responsible for the symptoms. Now, Children's Hospital of Philadelphia conducted the study afterwards, because the RGI Society, the National GI Society, funded, and they found no association between increasing abnormal behavior and use of polyethylene glycol. So I really want to reassure that if you're seeing hypersensitivity, it's not because of the chemical. It's probably some intolerance, which could happen. All of us don't exactly agree with the food that we eat, right? Some people don't do well with the beans, some people don't do well with the milk, and you don't have to have a disease for it. So I would not worry about it unless you're seeing a major issue. Now, if you are, then I think using one of the other osmotic laxative named lactulose is the only option that you have, technically. So we need to have this effect of osmosis. If you don't have the proper laxative, the use of other medication isn't really helpful, like Bisacodil or chocolate square or X-Lax. This is a bit different condition than regular constipation. So Jordan, I know it's not 100%, satisfactory without looking at the slide, but I will try to send that, and you can kind of study that paper and direct any questions. But as of now, I would say lactulose is the other option if the patient is failing to tolerate the Miralax.
Dr. Patel, thank you very much for your time and answering my question. I really appreciate it.
No problem. All right. Anything
Have
else?
any questions? Or?
I just have one other one, kind of following up on Jordan's. We've been struggling with like Miralose. We were on lactulose. I guess my question to you is that we've had GI consults, but to what we spoke to earlier, they're not maybe as well versed with cystic fibrosis.
Mm-hmm.
Do you recommend like continuing to follow up with a GI specialist? And or do you recommend any, I don't know, debriefing that we could give them?
You could say, the CF Foundation is starting a program called Visiting Professorship. Okay, this is a new program, and what it is essentially people like me who has this grant or digest award. They asked us to kind of make a presentation and upload or even virtually talk to the GI group, at your area, particularly the CF and GI related specifics. So you can explore that. The other option is always see someone, at least for kind of a, second opinion one time, and see if they have any different opinion. Unfortunately, that's the whole idea, to increase awareness, so there does not need to be a GI specific CF doctor, CF specific GI doctor. Every GI doctor would know about the CF rather than, because you can't increase or improve the access of care for 60,000 patients in America if you have to have 20 patient dispersed or 20 GI doctor dispersed across the state, right? So unfortunately, there is no one answer, but look into this visiting professorship program by CF Foundation.
Awesome, will do, thank you.
Again, I would say it's difficult to conduct the research because it's hard to conduct the research that you don't know what's going to be an outcome. And if it involves anesthesia and putting patient under the sleep, I'm hesitant to do that. So we have to have also, kind of doing the research in the ethical guidelines. That's why IB-STIM, it's a good thing because you're already doing in the clinic. You just need to evaluate in the CF population. So hopefully more patient and more advocate like you guys, would probably have enough influence on CF Foundation to fund people like me to do more studies, to pay for the time and things like that. Because hospital does not like Patel to sit in the office and just talk and just do the CF discussion. They want me to see patients in the clinic, and that's always a hard time, right? Otherwise it would be difficult for them to continue to employ me.
Amy, did you have a question? I think I saw your hand up.
Oh, I have a million questions, I'm sure, but I was going to ask, and forgive me here, but is there a reason why the FDA hasn't approved Miralax for a certain age group and under?
I think it's like one of those things that they are completely, hung up on the specific data and request and said, it breaks my heart to see on the Miralax bottles is do not use more than 2 weeks. It's just not and I don't know the reason. To be honest, we have our body, our society has not just the CF. CF is very realized that small population as opposed to GI. The whole GI society has kind of played like 1,000 times, like this needs to be approved. And it has not. And I don't know the reason. To be honest, I have to find out like why we are not approving the thing that is commonly used like every single day practice. I mean,
No.
you would be surprised to know the Zantac is off the table now, but now Pepcid and omeprazole, the PPI, there are no data, which works better. No one knows, it's very commonly done, use medication, but a lot of this NIH money goes to adult. So you will hear, well, in the VA hospital, the kidney failure happened with the proton pump inhibitors for this many patients, because that's where the studies gets conducted because of the funding. And that information translates to pediatric world much, much, much later.
I see. Do you mind if I ask one more question in
Yeah,
relation to gastroparesis?
Yeah.
I noticed the medications that are quite common that can help with gastroparesis, but I was curious to hear your insight on any procedures that could potentially help with that. There was one that was recommended our daughter have, and I kind of just put a hold on that. Out of curiosity.
Sure. Okay. So, and I think, you might be talking about pyloroplasty or Botox or gastric stimulator. Out of those three, has to be one. But in general, I recommend not to rush to do, any of those procedures right away, because that's almost like putting a bandit. It's not going to improve the CFTR function. And the reason I said, why to wait until for some time is because now that we have hope, Trikafta might actually change the way the GI tract functions. So gastric stimulator, those are good intervention for debilitated patient who has otherwise no like not a good quality of life, because of their symptoms, and they're not able to tolerate anything. The GJ tube is not an option from anatomic standpoint, or the family, either compliance or adherence to regimen, so it's more than one thing I can answer. But the stimulators are not shown to be a great, effective intervention for gastroparesis. People use it as a last resort. It doesn't mean that it's actually working. Actually nationwide, one of my friend who does that, and he also tells me that they try to select the patients from different criteria. They don't automatically do this procedure on everyone, because first of all, it requires your few months of a trial period, see how you do, and then it's a surgically implanted stimulator, which also is not without any issues. So that's a great dilemma you may have, when someone recommends from the GI community, well, that's the only thing you can get. It's difficult to know which way to go, but I would look into the prucalopride, if you haven't tried that already. The Botox injection may be somewhat better than going to go all the way to the gastric pacemaker or stimulator. Again, I don't have any specific, right to say, without understanding too, but these are my some general comments. I don't know if it's helpful or not.
That was incredibly helpful. Yes. Thank you. Thank you.
Thank you so much, Dr. Patel.
All right.
We
Well,
really
great. I hope,
appreciate
this was, somewhat, of help. And please let me know if you guys have any more questions. Okay.
Yes, thank you so much.
you.
And yes,
Thank you so much for your time.
No problem. Thank you. Take care, you guys.
Take care, Dr.
Well,
Patel. Thank
thanks
you.
a lot.
us.
Bye.
Did it.
Bye.
Good night.